Hello and welcome. I'm Steve Clemons. I'm editor-at-large of The Hill. Thanks so much for joining us today for our forum called The Future of Healthcare, Tackling Costs and Pathways to Care. Over the next 2 hours, we're going to hear from policymakers and stakeholders about resetting the care paradigm across the United States. We're going to do this in 2 sessions with a little short break in between. But for first, I'd like to thank our sponsor, Viatris, for its support of today's conversations. Even before COVID-19 created extraordinary challenges for the nation's communities, stark disparities existed across our healthcare landscape. As we begin to chart a path forward, how should we address the social and the economic and the environmental factors that influence health and access? How should we re-examine our traditional models of care to better fit the needs of all patients while keeping costs in line? And what role does increased competition play in promoting sustainable care and healthier communities overall? We've got a fantastic lineup of speakers joining us, including senators, city leaders, health equity experts, and lots more. Before we get underway, a few housekeeping notes. You can tweet us at The Hill Events, but more importantly, the hashtag The Hill Health, The Hill Health. We're broadcasting live and we'll take your questions throughout the program. And if you experience any trouble with the live stream, just refresh the page. Do not throw your computer out the window. It will all be okay, I'm told. Our first guest is Dr. Allison Arwady, the Commissioner of the Chicago Department of Public Health. Prior to this, she worked for the Centers for Disease Control as an Epidemic Intelligence Service officer. Dr. Arwady, it's great to be with you. Let me just, before I get into like the heavy stuff, I'm fascinated because I've been reading your bio that, you work with the Epidemic Intelligence Service as an officer there. And there's this broad infrastructure of public health people that I don't think most people think exists. And I just want to give people a pathway to understand that there are a lot of folks out there focused on public health. Tell us just a little bit about your journey.
Yeah, absolutely. I think a lot of people don't realize prior to COVID that there is a large infrastructure that is built with a very particular focus on thinking about how to be prepared for and to respond to outbreaks, epidemics, and now pandemics. So I was in a training program through the CDC called Epidemic Intelligence Service that takes fully trained physicians, veterinarians, PhD epidemiologists, postdoctoral folks who are fully practicing, and then basically has them work on outbreak response and learn all the details of that. So I had the opportunity to work on the Ebola outbreaks internationally, the Middle East respiratory syndrome internationally, outbreaks, all over the state of Illinois. And so when COVID came, if there's one thing in the world that I've been the best trained to work on, it is that. So it's an example. Public health flies under the radar a lot. We think a lot about the medical care, and I am a physician. I take care of patients, but really my main interest is about how you protect population health. And one of the very few good things about COVID is that I do think it's brought more attention to the field of public health, where we think not about a disease, we think about not an individual and their disease. We think about the community, the population, and how really the community can be our patient. And we've got to create better systems and better ways that people are able to stay healthy as well as get care after they become ill.
I really appreciate how you have framed this. My friend Lena Wen, is often out there saying, hey, public health saved your life today. You may not see it, you may not know it, but there's this infrastructure out there. But let's go to Chicago and what you're doing there. And my understanding is you're working on equity zones. I've been hearing on the economic side about opportunity zones that the last administration, current administration, but tell us about equity zones and health.
Yeah, absolutely. So just as you were leading off, here in Chicago, like so many places around the country, we were seeing very large inequities in health outcomes across Chicago. If you look at them by race and ethnicity, you take all comers on average, Black Chicagoans live about 9 years less long than other Chicagoans, even before COVID. And we've seen declining life expectancy for all racial and ethnic groups in Chicago, except white non-Latinx Chicagoans. And so really what we've seen in COVID, where things have been successful, it's where we've invested in communities, really said, you are the expert in your community. How can we get you funding, get you resources, hire from within those communities? In Chicago, we didn't hire, like most places did, a call bank to do our contact tracing. We hired about 600 people with no particular educational background, but who were very good at interacting with individuals hired them through our workforce training program and in conjunction with a lot of community-based organizations, some of whom had never worked in health before. And those 600 folks have gone on to do an amazing job throughout COVID. We wanted to really create that sort of community-based health equity-focused infrastructure across all of Chicago for whatever is coming next. So we've divided the whole city into these equity zones because no matter where you are, there are parts of Chicago that are largely being left out. It's harder to access care. They're not having all of the ability to perhaps get the resources that should be available. There are whole parts of the city that are disinvested from an economic perspective. And we're really funding these networks to make their own decisions about which priority health issues they want to be focused on. Right now, they're starting with vaccine, of course. That's a very focused thing. But after that, we're using some funding that's focused on health inequities. And if one group wants to work on the breast cancer racial disparities and have that be the focus, and one wants to do infant mortality, and one wants to be focused on drug user health and figuring out how to get those folks into housing, we're really working to create those networks and be prepared so that whenever something new is coming, we're not starting over from ground zero. We had all kinds of equipment here, all kinds of materials, N95 masks stocked. We were in so much better shape than a lot of the country in terms of the things related to preparedness, but that community infrastructure and a trusted group to be able to really carry those messages and work on keeping people safe outside of a pandemic is where we saw we're lacking. And so it's really our plan going forward to do most of our community-based work through these networks.
Sounds incredibly fascinating. And Dr. Arwady, I'm probably going to screw up how I ask this question, but, are you able to kind of monitor over time, I don't know, some measures in health to sort of look at what the impacts are? At the end of this show today, at the end of this summit, I have an interview with Senator Bill Cassidy. Folks, I already did the interview, so I know what we talked about. One of the things he talked about, he worked for 25 years as a doctor in like the prison system and, low socioeconomic status patients that needed different kinds of support. And he basically talked about a program that he's supportive of called Connected Moms. And it's to try to address maternal mortality differences across racial lines, in which there's, an absolutely horrible level of maternal mortality in the Black community, for instance. And so they're looking, and we talked a little bit about how you're going to measure over time whether you're going to be able to change this. So I guess I'm interested in models that work, and then show and tell, and then how can a lot of other folks replicate it so we find ourselves in a better place down the road. Any thoughts?
Yeah, absolutely. So here, even before COVID, we had set as the focus for the city the 5 main drivers of our racial life expectancy gap here in Chicago. Wow. Starts with chronic diseases, includes gun-related homicide. Number 3 is infant mortality. Maternal mortality is listed in there. With and then number 4 is the infectious diseases, HIV, and then now obviously COVID and other infectious diseases. And number 5 is opioid overdoses. And those are the focus. We do not define success when we are looking at how well we are doing as a city as what's happening to the average. Obviously, we want to see smoking rates go down, but we don't define success of did smoking rates go down. We say which group, whether that's a geographic group, a racial ethnic group, a socioeconomic group, a sexual orientation group, is furthest from the goal. And seeing improvements in that group toward the mean is really how we now define success in a true equity-focused way. And so even if you look at something like COVID vaccine, of course, we're watching where the whole city is going, but our primary focus is on the neighborhoods where our vaccine uptake remains lowest. And we judge our success on what is happening in those spaces, really not leave people behind. And we've been working to make sure, for example, that every single person in the city of Chicago can call a number and we will bring vaccine to your house for free, no questions. And it turns out that's actually a very cost-effective way to deliver this vaccine because you can have the individual conversations. You can build that trust. We like to bring together a group. We sort of vaccine and dinner together. And it's actually turned out to be more cost-effective, even though we thought it would be more expensive than a lot of the community pop-ups. And so I think this ability to actually look at your data, not start a program and wait 5 years, but every few weeks or months say, what are we learning here that's different? What's different in terms of cost? What's different in terms of access? That at-home program is the most popular in some of the parts of the city where access is lower. We have more Black Chicagoans than any other group taking up that particular route of accessing vaccine. But I think we could model that for so many other things. There's lots of data. You just have to look at it, and then really think about how do you not just admire a problem, but actually act on it and then evaluate that. If it didn't work, try something else. And COVID's been a great opportunity here in Chicago for us every few weeks in partnership with community to say what's working, what's not, and how do we adjust it. We want to do that for these other health inequities as well.
It's so cool talking to you. I wish you were a legislator, because then you could come and kind of, we could be out here in D.C. and then kind of, wrestle through some of these issues. But I guess the final question I have for you is along the lines of cost. You've talked a lot about cost. Yesterday, the Hill sponsored a forum dealing with diabetes and obesity, and I learned a lot about continuous glucose monitors and all sorts of new things that have hit a disease, couple diseases stacked up against each other, where there hasn't been a lot of development. But if you talk to folks across, again, the line of who benefits in America's healthcare system and who doesn't seem to be, cost is an issue for them. So how do you get around cost? And from your perch, which I know you're not making the decisions at the federal level, but from your perch, when it looks to the market on access and cost and competition, what are some of the things out there you think we need to know about when you're dealing in the field of cost and access?
Yeah, so right off the bat, I would start with recognizing that right now we put 1 or 2 pennies of every dollar into that preventive work. Much more of it goes on the treatment side. So, continuous glucose monitors, all of these advancements are amazing. Being able to actually fund a little more on the front end to actually help people keep from getting diabetes, or when they have prediabetes, what sort of investments and access can you work on at that point, actually is not where we typically fund, but it has the ability in a very cost-effective way to bring down some of those medical costs. The other thing is that we are, as you know, really just about the only industrialized country that has attached things like access to healthcare and insurance, either to job status, or to age with limits, or to low income. And that does leave a lot of people out, especially where you're talking about some of these amazing advances. I see patients in the largest free clinic here in Chicago. We see people who are not eligible for insurance. And boy, it is really challenging to know that there are amazing opportunities out there for treating their diabetes. And the clinic does a lot of work to make sure they can at least access the insulin, you can get these pieces in. But we have not built a system that recognizes, from my standpoint, healthcare is a human right. We've got to invest more on the preventive side, but then thinking about what is a baseline that regardless of whether you're working a job that gives you health insurance, you're actually able to access at least the basics, I think is something that is just incumbent on us, because those folks go on to have diabetes hospitalizations and much higher costs overall. And we treat people, at the other end after they've had a major heart attack, and you've got to go in and sort of pay for all of that care, where there's so much less expensive care available, but it's at the earlier preventive and often in the public health space.
Well, can I just tell you what a pleasure it is to talk with someone that I actually understand what you're saying. I can hear what you're saying, and I think the layperson out there can understand what you're saying. Thank you so much for joining us, Dr. Allison Arwady, Commissioner of Chicago's Department of Public Health. It's really been great speaking with you today.
Thank you so much.